Good morning. My name is Chris Braun. I'm from Brandenburg Medical School, Brandenburg Heart Center in Bernau near Berlin, Germany, and I want to present my study. Deep sternal wound infection and sternum instability is one of the major problems after heart surgery with median sternotomy. They occur in up to 6.1%. This results in three major problems. So, the morbidity increases, the mortality increases up to 47%. The increased length of treatment and hospitalization due to DSWI treatment generates immense treatment costs for society. What can we do to avoid deep sternal wound infection? First, we can tackle all avoidable risk factors like obesity. Second, we can wash patients with octanidine before the surgery to prevent MRSA. Third, we can do good patient selection before surgery. Fourth, we can use an antibiotic strategy. There are several studies which favor prophylactic vancomycin. Fifth, we can do a perfect sternal closure. Sixth, we can reduce the talking in the OR and much, much more. The study I am presenting today addresses the fifth point, the sternal closure. We examined the impact on the use of different wire techniques as well as double wires on its complications after sternal closure. What did we do? We studied 4,505 patients with a BMI greater than 30 who underwent cardiac surgery with median sternotomy over a 10-year period. We selected 5 groups depending on the wiring technique. In the first group, we included 1,076 patients who got stainless steel single wires. 1,703 were included in the second group, in which single wires and figure-of-8 wires were applied, but mainly single wires. In the third group, we included 1,210 patients with more figure-of-8 wires than single wires. And in the fourth group, we included 616 patients who just got figure-of-8 wires. And last not least, we included 703 patients in a group where patients got a mix of single wires and double wires. The data was retrospectively analyzed. We collected the wiring technique from each patient's postoperative X-ray. Patients were at the same age across the groups 1 to 4. Sorry, this is the main slide. The double wire group was significantly younger at 7.3 years. The proportion of females was approximately 1/3, except in the double wire group with 17%. The BMI was highest in the double wire group. Interestingly, the Euroscore was lowest in the double wire group. The aortic clamping time was longest in the single wire group and became gradually shorter until the figure-of-8 group. The cross clamping of the double wire group was as high as of group number 1 and 2. The operation time decreased across the groups, but was highest in the double wire group with about 250 minutes. Diabetes was not equally distributed in the groups. Surprisingly, there were more fat people in the figure-of-8 group than in the single wire group. Postoperative delirium was equally distributed within the groups. It was highest in the figure-of-8 group. 23% suffered from delirium in that group. The Cochrane-Armitage test for Trent showed significantly less DSWI with the more figure-of-8 wire were used. The highest rate of sternal instability was again found in the single wire and double wire groups. Same with fractured sternums. There was a trend for less fractured sternums across the groups 1 to 4. The wire refixation was most necessary in the double wire group, and there was no case in the figure of 8 group. The removal of broken and torn out wires was again highest in the single wire and double wire group and low in the figure of 8 group. What are our main findings? We found that the greater the proportion of figure of 8 wires used by the surgeon to close the sternum, the less frequently deep sternal wound healing defects, NSI, occurred. The figure of 8 wire technique was also associated with reduced hospital mortality and incidence of a fractured sternum. The need for sternal wire removal due to an unstable sternum was also less frequent. We demonstrated that within our study population, deep sternal wound healing disorders and wire-related adverse events did not differ significantly between the single wire group and the double wire group. Our data support the recommendation for the use of figure of 8 wires for sternal closure after median sternotomy because of their significant reduction in DSWI and sternum instability. The cardiac surgeon may decide on an individual basis whether to use double wires for sternal closure because our data did not demonstrate superior effects in terms of avoiding DSWI and sternal instability after median sternotomy. Thank you for your attention and giving me the great opportunity to show you my study, and I want to say happy birthday to my lovely colleague, Dr. Ostovar. Thank you.
Thank you. Well, thank you very much. Yes, happy birthday also. And sorry for not naming you correctly. The system got me a little bit confused. Christian Brown was the speaker. Are there any questions on the floor?
Marek Deja, Katowice, Poland. I have 2 questions, actually, if I may. First, congratulations, a beautiful study, but one is the technical question. Were the wires passed around the sternum or through the sternum, and did you take it into consideration? And second, have you taken the surgeon factor into consideration? I mean, because probably some surgeons prefer one technique, some surgeons prefer the other technique, so it might well be that you're comparing surgeons rather than the technique itself, plus what percentage was closed by trainees and what percentage was closed by a fully trained surgeon, which might influence the result as well.
Thank you for the question. At our department, the surgeons decide on individually their technique for sternal closure. I think in most surgeons perform the transsternal wiring technique compared to the peristernal wiring technique. So all the factors like trainees, like surgeons, and like the peristernal versus transsternal technique was equally distributed over the number of patients. So we could concentrate we could put them quite out of the study and trust that we studied what we wanted to study.
Thank you. I'm Branislav Bezak from Bratislava, Slovakia. Thank you very much for your presentation. I wanted to ask, when you're using the figure of 8 for closing, do you cross the wires or do you place them separately?
Cross the wires or what?
You know, like you can interlock the figure of 8 wires, or you don't interlock them?
Yeah. When I understood you right, I think we cross. What you mean we cross?
No, by looking at the X-rays you showed at the beginning, that was not crossing one wire with the other, you mean?
Yes.
And trapping the first one with the second, the third, that's
yes.
what...
Yes.
Yes, that's what I mean, that you can interlock.
No, I don't think you put them separate, right?
Yes,
we could separate it, clearly,
okay.
yes.
Okay. I didn't catch it on the X-ray, but thank you very much.
I just had one question. Do you know how many patients you included with bilateral internal mammary? I myself use 78% beam in my coronary practice, and I did use the figure of 8, and I found, and I know it's anecdotal, but I found an increased infection because you are sometimes killing, if they're skeletonized mammary, you're killing the collateral support. Do you know how many BEMAs you did?
Yeah, in Germany we have a so-called quality control. We obliged to do the EMA on every patient where it is possible. But we included all patients, aortic valve replacements and CABG. And so we were very careful by doing the wiring technique, and so we tried not to harm the EMA.
But do you do double mammaries? One mammary is not a problem. It's two mammaries that make the difference.
The double EMA was not done so often, most the single EMA.
Okay, thank you.
Albus is my name. I'm the head of the department and I'm his boss. So we actually, in this retrospective study, all patients were analyzed, and so the roughly said the proportion of double EMA was very low, yeah. And we did not. But when we also looked at double EMA patients, and we did not encounter the problem which you said, but we think that a transsternal wiring technique is better than a parasternal wiring technique because you tend to kill the last remaining collaterals to the edge of the sternum. So I strongly support the finding that it is better to do a transsternal, not parasternal.
Many wires rather than... Yes.
Yeah, many.
Yes, 8, 9, 10.
Yeah, we don't go around. Very seldom we go around. Very, very seldom.
Okay.
Just in selected cases.
Around, I think when the sternum is a reasonably good quality, it's better to go around.
Through here, okay.
And it's very stable, and there's multiple studies shown on the cadavers that very stable. But however, if the bone is soft and
that's not good.
and osteoporotic, I would agree. That's
Go through. Thank you. Just one last very quick question, Juan, because we're getting
I just
over
wanted
time.
to, very quickly, do you control for the soft tissue closure as well? Or
You
not?
had a comment?
It's just soft tissue closure and skin closure homogeneous among the groups?
The tissue closure are homogeneous over the groups.
Yeah, I mean,
Was it
you're
the
talking
same for
about
every
the
patient?
close of the sternum. I think your boss is coming to answer.
Yeah.
May I?
Yes, please.
So that's very homogeneous. Skin closure is always done with clips and two lines of subcutaneous closure.
Thank
It's very, very homogeneous.
Thank you, Professor. And Peter has...
I just, as a young surgeon, was speaking 20 years ago with Mr. Robichek, and he told me it doesn't matter how you close the sternum. The most important layer is fascia, how you close the fascia. If you close the fascia with a periosteum, because in the very beginning there is no stable sternum. Stable is going always like that, a little bit. And when you close the fascia in the perfect way, then you stabilize the sternum.
Thank you.
Just one very brief comment, but you can see from the intensity of the discussion that something as minor is actually very important for the outcome. And the discussion has been going on for 50 years. And yes, the surgeon is important and the fascia, everything. But there are physics. If you have one wire at 90 degrees,
Exactly.
you can still have a shifting sternum. And this is the worst you can have, that the sternum heals late. If you have a V-shaped distribution, the sternum cannot shift against each other. So it's physics, and one can argue endlessly if it's the registrar, the surgeon, but physics have been clearly in favor of figure of 8 for the last 50 years, and we still passionately discuss it.
Cadavers do not support what you say.
No, but physics do.
Okay. We should...
And the wires
I think
can
let's
cut
move on.
through the bones. The single wires, more easily than the figure of 8 wires. Yeah, the perfect sternal closure, I think, is...
It's not doing a sternotomy.
Yeah, no, yes, that's true. Yes, doing minimally
But we
invasive.
need to.
Okay, we should move on.
Thank you.